Well, more than ever, we recognize that you all have many competing priorities. The most glaring, of course, is our continued struggle with the COVID pandemic. In Colorado, nearly 80,000 cases have been reported with over 2,100 deaths. Moreover, our case positivity rate is again trending upward, nearing 5%. And most worrisome is the continued inequity in the populations impacted by the virus. Shown here are weekly percent COVID cases by race ethnicity. We see that while the Hispanic population comprises about 20% of the Colorado population, they comprise nearly 40% of positive cases. For COVID-related deaths, while Black Coloradans comprise less than 3.9% of our state population, they comprise 6.3% of all deaths. This year has been like nothing we've ever experienced in our lifetimes. And for our families impacted by substance use disorders, we know anecdotally that this tumultuous year has created even more barriers to sobriety, recovery, and stability. But today, seeing the number of people participating this morning in this forum, the fact that you are all here despite everything else going on in your lives is the clearest evidence that we are not only optimistic and hopeful for better times, but that we actively want to be part of the solution to make things better for our neighbors, our families, and our children. Your compassion and dedication to our families does not go unnoticed, so thank you. We have a fantastic day planned for you. And I know 9 a.m. to 3 p.m. for a virtual platform seems long, but I promise you it'll go by quickly and you'll learn a lot and have a great time. And so we are in the midst of welcome and introductions currently. Following this, we'll provide some updates. Our keynote presentations will then follow from folks from Massachusetts. We'll then have hospital updates focused on many of the key drivers that you all have been working on. We'll have lunch and a yoga break from 12 to 12:30. Following that, we'll have a great afternoon hearing from mothers and families impacted by substance use disorders in the lived experience session. We'll have breakout sessions following that, and these are the 4 that I hope you all have hopefully signed up for. And if you have not, please do chat in so our meeting coordinator, Cassie, can get you plugged in. And then we'll have a forum wrap up from 2:30 to 3. Like I said, a great day of learning and engagement. We're going to move on to our collaborative level updates. I'll start with an overview and a dated update. Jaime Cabrera from CPCQC will highlight some of the funding that we have secured or are upcoming. And then Jade Woodard from Illuminate will provide overall state efforts around care of the substance exposed newborn. And so this is a slide that I share often at all of these meetings, but it's to highlight the population level burden of opioid abuse or dependence during pregnancy that we are having to confront. We know that since the 90s into present times, there have been an astronomical increase in opioid abuse or dependence in our general population, and that has been mirrored amongst women birthing individuals during pregnancy. We know that the prevalence of opioid abuse or dependence during pregnancy has increased by 130%, from 1.7 per 1,000 births in 1998 to 3.9 per 1,000 births in 2011. And the most substantial increase in opioid dependence has occurred within the age group of 20 to 34-year-old, the largest population of birthing individuals. And therefore, subsequent to that, we've been seeing significant increases in neonatal abstinence syndrome across the US. We know that there's tremendous variation across states. For instance, in Hawaii in 2013, the NAS incidence was 0.7 per 1,000 hospital births, while in West Virginia, NAS incidence was 33.4 cases per 1,000 hospital births. Here in Colorado, it's estimated that we range anywhere from 1 to 5 per 1,000 live births, but we've come to realize from our CHoSEN Quick database that our incidence is actually close to 11 or 12 per 1,000 live births, so nearly double what's publicly reported. You know, while as a neonatologist, I tend to focus on the baby, we can't lose sight of how this is affecting mothers directly. In the recently released report from the Colorado Maternal Mortality Prevention Program, we learned that suicide and drug overdose were the leading causes of pregnancy-associated deaths in our state. Nearly 2/3 of maternal deaths were related to substance use and mental health disorders, with the majority deemed preventable by the Maternal Mortality Review Committee. And so in the setting of this tremendous public health crisis, we had observational data here in our state and some signals of adverse outcomes among neonates. And so we then sought to understand how opioid exposed newborns were cared for in Colorado. And as many of you on this call know, we tried to understand what was happening at birthing hospitals. And we knew that there was a lot of variability across our hospitals, from screening to assessment for withdrawal, to the location of where infants were cared for, how mothers and families were engaged, what pharmacologic modalities were being used, and what were the criteria for discharge, and on and on and on. And therefore, CHoSEN QIC was formed. And I always like to highlight our goals because it shows what the pillars of this collaborative are. We wanted to develop a collaborative quality improvement initiative of Colorado hospitals that uses structured quality improvement methods and sharing of data and practices to further support hospital-based improvement efforts to achieve measurable improvements in the care of substance-exposed newborns and their families. And so this effort was really founded upon being collaborative, being transparent in our data and also our intervention approaches, having open sharing and learning from each other. When we first started in September of 2017, we had 6 hospitals staffed mainly by the physicians from the university. We hadn't done a whole lot. We had a team lead identified, and that was really it. But with the development of critical collaborations with Illuminate Colorado and our state's perinatal quality collaborative, we've grown very quickly, such that by the second quarter of this year, we have over 30 hospitals throughout Colorado, Wyoming, and Montana that are actively engaged in CHoSEN QIC, and we have nearly 20 hospitals that are contributing data to our central data system. And here in Colorado, nearly 50% of all births now occur in a hospital participating in CHoSEN QIC. Shown here is our key driver diagram. And as many of you know, we sought to first improve the hospital-based care of substance-exposed newborns and to optimize the discharge process for these infants. We recognized that we were a hospital-based effort with not much data and information about what happens to these infants and families post-discharge, but we thought we could at least hope to optimize that transition home. Our primary drivers were focused on increasing and improving participation, initially of Colorado hospitals, and now we've expanded and we consider ourselves truly a quality improvement collaborative of the Rocky Mountain region. We sought to reduce postnatal exposure to opiates by improving non-pharmacologic care, standardizing the use of human mother's own milk, and implementing the ESC assessment tool. We wanted to increase family involvement really through antenatal counseling so that families were aware of what to expect during the birth hospitalization. And we wanted to improve the discharge process and working closely with our state partners around the operationalization of plans of safe care during birth hospitalization. And we're happy to report that we can now publicly share our work. This is our recently published paper in Hospital Pediatrics that came out just last month. And I think what I'm probably most proud of is the fact that our long author list truly includes all those people from these organizations listed that have worked tirelessly to support this population of families, mothers, and infants impacted by substance use disorders. Let's move on to data. And so this is also a slide, excuse me, that I share often, that without data, you're just another person with an opinion. And therefore, our collaborative was always rooted in being data-driven. Shown here are some limited sociodemographic characteristics of birthing individuals captured in our data set. Thus far, we have a total of 1,234 substance-exposed newborns in our data set and a little over 1,000 opioid-exposed newborns in our data set. And the discrepancy lies in that there are some hospitals that have chosen to capture data, enter data into our data system, even if there was not opioid exposure, but some other substance exposure. We can see that nearly 2/3 of our mothers are white, and unfortunately, 28% are reported as missing or unknown. And so this is the limitation of pulling data from our electronic medical records, that we are lacking this really important information about maternal race. You can see that for ethnicity, about 63% of our mothers are reported as non-Hispanic, and 28% are Hispanic, with 9% being missing or unknown. In terms of maternal insurance, nearly 90% are publicly insured. Shown here are the maternal substance exposures that are captured in our data system. First, you'll note that 57% of our mothers are engaged in some type of medication-assisted treatment. Now, we do have to preface this by saying that our definition of MAT was limited, and that mothers were categorized as receiving MAT if their exposure during pregnancy included methadone, buprenorphine, and Suboxone. Unfortunately, among that 57% of mothers who are receiving some sort of MAT, 69% had also reported use of illicit substances. And therefore, while MAT was ongoing throughout pregnancy, there was still the presence of illicit substance use amongst these birthing individuals. We have 43% of mothers without any MAT recorded. And amongst that, we see that illicit opiates with the combination of other substances comprises the majority of that group. If we think about co-exposures, in addition to that primary opiate exposure, we see that for opiate exposure, the majority is heroin, 29% is prescribed methadone, 28% buprenorphine, 15% illicit opiates, 50% prescribed opiates, and 9% unknown. And so this also highlights that amongst mothers who have opiate exposure, still the majority are taking illicit substances that are not prescribed. Shown here are the frequency of non-opiate co-exposures. The top three are methamphetamines, nicotine, and marijuana. Now we're going to move on to our process control charts for our outcomes of interest. Shown here is the average length of stay for our opioid-exposed newborns. For this process control chart, we've limited our analyses to infants that are greater than or equal to 35 weeks and whose length of stay is not affected by other diagnoses that could potentially result in a longer length of stay. So here we have represented 826 infants. You can see significant declines in our average length of stay from our baseline mean of about 14 days down to most recently about 9.3 days. At our lowest in the first quarter of 2019, we had gone down to about 6 days. Here we see the percentage of opioid-exposed newborns who received pharmacologic therapy for withdrawal. When we first started, our baseline mean was 55%. And the very first quarter of data collection, we were at 60%. And then most recently, our new mean is 23%. And then in the most recent quarter at 25.4%. At our lowest, again, first quarter of 2019, we had a percentage of 16.5%. You'll note that in April to June of 2020, both in terms of receipt of pharmacologic treatment and length of stay, we saw an increase, a reversal in the trend that we had been witnessing. And we were a little concerned that this might have been the COVID effect, that we had heard from hospitals that limitations on parental visitation, changes in nursing staffing may have limited a non-pharmacologic treatment of these infants and may potentially have led to increased use of pharmacologic therapy and subsequently increased length of stay. But fortunately, we are starting to see that curve come back down in the most recent quarter. So we'll certainly follow it closely. Here we see the average length of stay for those infants who required pharmacologic therapy. We saw significant declines from 22 days, or a baseline mean of 20.8 days, to a low of 9.5 days in the first quarter of 2019. We saw an uptick in spring of 2020 to 16.4 days, and most recently, we're back down to 12 days, and our new mean is at 13.1 days. We are collecting data on eligible infants to receive mother's own milk. A big part of this effort was trying to standardize our guidelines for provision of mother's own milk. The hope it was to reduce the bias on which mothers would be allowed to provide human milk versus not. And so this is the percentage of opioid exposed newborns who were actually eligible to receive mother's breast milk based upon our guidelines, and then who were actually discharged to biologic parents. And so here we don't have a significant change, but there are some signals that we have to follow. When we first started, eligibility was close to 87%. And most recently we're at 66%, while, based upon rules of process control charts, this is not a significant change, but it certainly warrants monitoring and wondering if there is more illicit substance use among mothers, and potentially more mothers who are not taking their infants home after birth hospitalization. And so certainly more data is needed for us to observe these trends. Here we have, among infants eligible to receive mother's own milk, how many are actually receiving breast milk. Here we see that we started off at 81%, or a baseline mean of 84%. And again, this line hasn't changed significantly, but we are still seeing some movement, and most recently at the last quarter of 67%. And so this too will require close monitoring. While we are a hospital-based effort, as I mentioned, we are trying to optimize that discharge process. And one of the things that we have to have in place, or want to have in place, is that early intervention referral before hospital discharge. We know that here in Colorado, just because an infant was substance exposed in utero, that does not automatically qualify you to receive EI services. But we recognize that having that initial assessment for that high-risk group of infants is important. And ideally, we would like to have this referral in place. When we first started, we had about 25% of infants had an EI referral around the time of discharge, with a mean of 22%. And most recently, we have improved up to 40%. So we've improved significantly, but we recognize that we're still far from where we need to be. And so I'm very excited to hear from Dr. Diop about Massachusetts' efforts around early intervention referral. We also recognize that in order to effectively engage families, we had to provide good counseling and education so that families were aware of what to expect. And so the receipt of antenatal counseling remains far from optimal. We are seeing some increases, however. When we first started, the baseline mean was at 5%, and most recently our new mean is 11.7%. We had a peak in the first quarter of 2020 of 19.4%, then potentially a trend downward. I will say that for this measure, a lot of our data is missing or unknown. And so there's certainly a data problem that we need to address, that the communication from the prenatal period to the birth hospitalization is lacking, such that those during birth hospitalization don't really even know if counseling occurred and where that data lives. And so lots of work around data that we have to do here. Shown here are the percentage of opioid-exposed newborns that received a handoff to a primary care physician. Here we also have seen increases from a baseline mean of 16% to a new mean of close to 26%. Again, most recently, the last 2 quarters, we've seen a downward trend. And again, I wonder about the COVID effects and sort of competing priorities. But again, we'll be watching this very closely. As I mentioned, we are collecting some limited sociodemographic information so that we can better understand if we are increasing or improving racial ethnic disparities in our outcomes in our state. Now, we have a very small Black birthing population in Colorado, and then if we limit that further to women with opioid use disorders, it's very small. We do have, as I mentioned, a quarter of our birthing individuals are of Hispanic ethnicity, and so we have been able to do some limited comparisons for some of our outcomes. So on the upper process control chart, this is average length of stay of opioid exposed newborns born to Hispanic mothers versus on the bottom, this is non-Hispanic. What you notice is that in terms of where both groups start and where they end up is comparable, where the initial mean is in the low teens, and the new mean is close to 7 days. But what you'll notice is how much longer it takes infants born to Hispanic mothers to reach that new mean. For non-Hispanic mothers, that change occurs within 1 quarter, whereas for the Hispanic population, it takes over a year for that new mean to be reached. Shown here are a percentage of OENs born to Hispanic mothers who receive pharmacologic therapy on the top graph, and on the bottom, these are amongst infants born to non-Hispanic mothers. And again, we see that both groups eventually end up at similar places with improvements in these percentages, but it takes longer in the Hispanic group. And then lastly, here we have the average length of stay of infants who received pharmacologic treatment. Again, the upper curve is for Hispanic infants, and then the bottom is non-Hispanic. And again, the trend is similar, where infants of both groups end up in the same place, but it takes much longer for the infants in the Hispanic group to reach that process change by more than a year. And so we're starting to dive deep into what may be the factors associated with this longer length of reaching these positive outcomes amongst our Hispanic population. Blair Weichel, who is our quality improvement specialist and data analyst, is working hard in looking at this data very critically and then developing her publication as well. So much more to come on that. And in addition to racial ethnic disparities, the other part that we have to acknowledge is that while outcomes have improved around length of stay, farm treatment, etc., there continues to be a lot of variability. Shown here are the average length of stays of opioid-exposed newborns by hospital, so that each of these bars represents a different birthing hospital in our collaborative. And you can see there's so much variability, where we have length of stays of nearly 13 days in Hospital D and down to a low of 2.7 days in Hospital C. The other thing that's notable is the burden of caring for these infants across hospitals, where we have hospitals A, D, and F with very large numbers compared to some other hospitals that have single digits. Here we have percentage of OENs receiving farm therapy by hospital. So while the number of overall receipt of farm therapy has improved for our cohort, the variability across our hospitals is significant, where we have some hospitals where infants are not treated at all. Granted, some of these numbers are small, and some where nearly all of them are treated. So in summary, for this data update, I would say we still have a lot of work to do around understanding the factors associated with the disparities and inequities that we're seeing in our population. In addition, how do we go about learning from each other so that this hospital-wide variation reduces over time? I'll now turn it over to Jaime Cabrera, Executive Director of CPCQC, to highlight some of the funding for opioid-related work.
Thanks, Susan. Good morning, everyone. I just want to take a brief moment to acknowledge critical funding that we've recently received. As Susan mentioned, you can see the data speaks for itself. The learning collaborative model works, it's effective. And the funding to provide technical assistance and bring everybody together in forums like today is very important. And so recently we received additional funding to expand the current work and also grow that work to include pregnant and postpartum people. So you'll hopefully join us for a breakout session to talk a little bit about what we learned in our pilot, looking at treatment for women with opioid use disorder prenatally, focusing on screening and referral to treatment and follow-up for care. And so I want to thank our funders, and I want to encourage you to continue doing this work because it continues to be a priority for funders, both nationally and locally. So thanks again for being here. Thank you to our funders, and we look forward to a really exciting day to continue to grow this effort.
Terrific. Now we'll hand it over to Jade Woodard, Executive Director of Illuminate Colorado.
Good morning, everyone. Thanks so much for being here. I'll add 2 funders to the list that Jaime just mentioned. I want to make sure we also thank the Colorado Attorney General's Office and the Colorado Department of Human Services as well that have been invested in this work. So you see here the overview of the Substance Exposed Newborn Steering Committee. I know we've provided this update at pretty much every CHoSEN forum, so just want to make sure everyone kind of has top of mind how the CHoSEN Collaborative and really CHoSEN Quick fit into this larger state structure. So the Substance Exposed Newborn Steering Committee is a state level group that has been meeting for over a decade to really consider prenatal substance exposure, impacts on maternal health and impacts on child health, as well as connections with child maltreatment. We have a family advisory board. You will hear from some of our family advisory board members later today to really share some of that lived experience. And it's really a way that we are ensuring that the work of the SEN Steering Committee is closely informed by the families that are most impacted. In addition, we have the 6 work groups you'll see here. These work groups were a part of our 2018 to 2020 strategic plan. All are in the process of actually wrapping up their 18 to 20 goals and activities and creating recommendations for what comes next. So we're really excited that we will be starting a new round of strategic planning, or we're in the midst of a new round of strategic planning right now. And so at the end of October, we'll do our next round, and we'll be kind of looking at, are these still the priority areas? Are these still the work groups? Where have we had significant progress? Where do we need to think about shifting our focus, and what's still needed? So we're really anxious to continue that conversation and to move to the next level, and to have really this work be broadly informed. So stay tuned, and you'll hear more about how to be connected with the Substance Exposed Newborn Steering Committee and hear from the group on what opportunities there are and really inform that work as well. And then next slide, Susan. And then also wanted to just provide a few policy or systems updates. So I think we shared in the May forum that we have been working for several years on a change to the Children's Code around prenatal substance exposure and really the definition of child abuse or child neglect at time of birth based on a positive test. So this year, 2020, in the midst of COVID craziness, the legislature came back for a short second session or a short second half to the session, I guess, in June. And at that point, the changes did pass in Senate Bill 2028. So we're now entering a rulemaking process to really define how will the changes in the definitional language and statute be applied in practice. So stay tuned if that's something you're interested in, if you want to really think through or participate in conversations with at least us on how we're informing what a positive test at birth means, or what child abuse reporting needs to look like at time of delivery. Please contact us. There'll be more information on how to do that. There's also rulemaking happening around plans of safe care. I know we provided updates on plans of safe care here many times in the past, but essentially federal law requires an infant that is born and identified as prenatally exposed to a substance for there to be a notification to the Department of Human Services, as well as a plan of safe care put into place. So there's been a lot of work, there's been pilots, and I think you've heard about those in the past. There's now rulemaking that will be developed to really guide implementation of plans of safe care across the state. So lots of opportunities for us to be influencing how the systems are working together to support families in these kind of critical transitions and critical time periods. Finally, through Illuminate, we're working on a handful of other projects, including projects that are supporting childcare for families that are in substance use disorder treatment, Circle of Parents, which is a parent support program for parents that are in recovery, a federal grant to support that expansion now, and then some additional resources and materials on understanding how to talk to families around substance use and what kind of toxicology tests really mean from at least a child welfare perspective. So that's a brief update of some of the things happening on a systems level. And as always, we'd love to hear from you or share more as makes sense. So thank you so much, Susan, and I'll turn it back over.
Great, thanks so much, Jaime and Jade. We have a couple minutes, and so I was wondering if there are any questions. Folks can either unmute themselves and or chat in a question for the three of us. All right, I'll keep an eye on the chat.